my life has been. So I was born and raised in Nigeria, which is in West Africa, and that's where I did all my pre-university education. After which I went to Ghana and did my bachelor's degree in biochemistry at the University of Ghana in Accra. And then I moved to Europe and I did my master's in public health at the University to North America, and I did my PhD at the University of British Columbia in reproductive and developmental sciences in Vancouver. And after my PhD, I moved to the other end of Canada and I did my postdoc in the university in Montreal. And then towards the end of my postdoc, I got a research fellowship. So I went to Norway for 2 months to do some work on cardiovascular disease. And then I just moved to the US last year. So I consider myself a global citizen, and having lived in all those places have exposed me to different research, education, and health systems, and it shaped both my personal and research journey. So my overall research vision is to better understand adverse hereditary risk factors, student ratio related factors, and predict short and long-term adverse outcomes after pregnancy complications using epidemiological methods. And my ultimate goal is to contribute in improving maternal and child health and reducing health disparities. So why do we study pregnancy? As most of you know, pregnancy is the time when most women come to the hospital. And so that provides an opportunity for her healthcare provider to assess her clinically and try to intervene for any health outcomes. And there's been a lot of studies suggesting that pregnancy is a window to women's future health because so pregnancy complications like eclampsia and stillbirth are linked with long-term adverse or chronic outcomes. Also, we know that pregnancy complications as well as long-term outcomes like cardiovascular disease disproportionately affect some women, like Black men like myself, as well as some minority and vulnerable groups. And that's why I mentioned helping to bridge the gap in health previous life. And so because of this, we use pregnancy period to try to find unique opportunities to monitor the health of women and to intervene where necessary. So I have several research areas and interests that I do work on, but I like to broadly group them into 3 main themes, with the pregnant population as the denominator and the vulnerable groups, maternal and child health as an overarching. So the first research domain is risk prediction modeling, and the second one is examining population risk factors, and the third one is perinatal pharmacoepidemiology. So I published work in these areas, but today I'll mostly talk about the first 2 domains. So the first one on risk prediction modeling, just for the benefit of all, clinical prediction models are tools for predicting future health. And a common example is the APGAR score, which is used to predict neonatal survival at the time of birth. And they usually have more than one variable, so they're multi-variable. And the aim of prediction model is to help to identify high-risk population of groups so that the doctor or the clinician can improve prognosis through early prevention or treatment or targeted management. And it also helps with shared clinical decision making because the clinician can communicate the risk with the patient. So one work I did in this area was during my PhD where I assessed the external validity of a prediction model. And this work was published in Pregnancy Hypertension. So the name of the model was called the full care model for preeclampsia, and it was developed to predict severe adverse maternal outcomes within 48 hours for women who were admitted with preeclampsia. And the model was developed to help to guide decision making, such as administration of corticosteroids, transfer to higher subspecialty antenatal care, and also to guide the clinician on when to do that the woman. And the model was developed using data from tertiary centers in 9 countries, including Canada, Australia, New Zealand, and the UK. And it incorporated easily measured variables like gestational age, signs and symptoms of preeclampsia, and some laboratory tests. Now, the model was assessed based on discrimination, which distinguishes between low and high risk groups, and also calibration. And the model showed high discriminatory performance. So the area under the rock was 0.88, which means that 88% of the time the model will be able to distinguish between those who go on to have a severe maternal outcome from those who do not. However, before a model can be introduced into clinical practice, it's highly recommended that the model is externally assessed, which is also called external validation, and it just means testing the model in a new data other than the one it was originally developed, just to see if it's translatable or generalizable. And so this is where I came into this project, and it was funded by the Canadian Institute of Health Research, CIHR. So for my project, I collected data from health records, also in high-income countries, so including Canada, the UK, Finland, and the US. And I collected data for similar populations, so women who had preeclampsia and the same predictor variables that were in the model and the outcomes. And I applied the model equations to calculate the predicted probability of the outcome for each case. And I assessed the model by the standard model assessment, so discrimination, calculation, and risk stratification. So in total, I had about 2,100 women. And when I tested the model in the new population, it showed distributing the high discriminatory performance. So the area under the rock was 0.88. Anyway, so in the figure on the left side, that was me testing the model in high income countries, and it had good performance. And then when I tested it in data collected from low and medium income countries, performance was slightly reduced, but it was still good. So the area under the rock was 0.77. And so my study showed that the full Pierce model is externally valid for the prediction of severe maternal outcomes in women admitted with preeclampsia. And based on my work, this model was recommended by the UK NICE guidelines, NICE International Institute of Health and Care Excellence. And so it was recommended by this guideline to use as a tool for the management of preeclampsia and other hypertensive disorders of pregnancy. And so the impact that this work has is that women who are most likely to have severe outcomes can now be identified using the model and manage more timely and appropriately to prevent these outcomes. So after doing this work, where I realized that we could predict short-term outcomes after pregnancy complication, made me think about long-term outcomes and whether we could predict long-term outcomes in such high-risk population. And I talk about long-term outcomes because, like I previously mentioned, that some of this pregnancy complications, especially preeclampsia and other hypertensive disorders of pregnancy, HPD, are linked with increased risk of cardiovascular disease. And if we're able to identify the women who are at high risk of this of cardiovascular disease, then that can help us with early prevention. Now, there are already some existing cardiovascular risk prediction models like the Framingham model, but they're not appropriate for younger population because they were not developed using young population cohort. And at the time when I was doing this, there was no prediction model developed for this particular group. And so that led to my first postdoc study, where I conducted a study to predict the 10-year risk of premature cardiovascular disease in women who had a history of hypertensive disorders of pregnancy. And by premature, I mean cardiovascular disease happening before 60 years of age. And this work was published in JAHA, so Journal of American Heart Association. So for this work, I used the hospital discharge abstract database in Quebec, which contains the ICD diagnostic codes from district summary in the medical records for all hospitalizations in the province. And if you're not familiar with the Canadian health system, it's more universal than here. So most people who, if you're registered in Canada, you have access to the healthcare system. So most people have their records there. And also about 98% of all deliveries in the province take place in the hospital. So I had data from 1989 and subsequently. And then I restricted my cohort to women, pregnant people who had at least one type of hypertensive disorder of pregnancy. So either chronic hypertension, which happens 20 weeks, which is diagnosed 20 weeks before pregnancy, or 20 weeks of gestation, sorry. Or if the woman had gestational hypertension, which is from 20 weeks gestation, or she had preeclampsia, which is gestational hypertension and proteinuria or some adverse features. And the outcome for the study was hospitalization for any cardiovascular disease, such as heart disease and cerebrovascular disease, occurring within 10 years of delivery. And I identified the hypertension pregnancy and cardiovascular disease diagnostic and intervention goals. So I excluded women who had pre-existing cardiovascular disease from this cohort, or if the woman had died of that pregnancy, but she could not be followed up. And then women were followed from the first pregnancy that was complicated with hypertension until 10 years thereafter, or until the end of the study period. And I used cost regression models to develop cost regression analysis to develop this model, and use the lasso technique to select the predictors. And then I assessed the internal model using the strap method, and assessed the model based on estimation calculation. So just to be on the population characteristics, in total we had about 95,000 women who had hypertension in pregnancy, of which 1.6% had cardiovascular disease within 10 years. And when we looked at comparing those who had cardiovascular disease with those who did not, we saw that those who had cardiovascular disease were more likely to be older at the time of delivery, so that 5 years and above. They were also more likely to be socioeconomically disadvantaged, and to have used substance in pregnancy, and have some form of pre-existing comorbidity like obesity and diabetes at the time of pregnancy. So the final model included about 10 variables, including social demographics like maternal age, and some pregnancy-related variables like the type of pregnancy. And if you see from the plot, the area under the rock was 0.66, so it had a moderate performance, and then the calibration slope was good. So the take home from this study was that easily available variables in a main data set can moderately predict cardiovascular disease in women with a history of hypertension in pregnancy, although there's need to improve this model, perhaps by using more discriminating variables like blood pressure measurements and laboratory tests, which we didn't have available in the admin data set. And then after which is also needs to externally validate the model. Yet we still believe that there's potential for this model, or a model that can perform well to improve cardiovascular prevention in women through targeted intervention. So moving on to my second theme, which is on examining population risk factors and describing pregnancy complications, severe maternal morbidity, and outcomes. So just a bit of background on severe maternal morbidity, which is otherwise known as SMM. So these are life-threatening conditions such as severe preeclampsia, cardiac complication, and renal failure that happen to a woman around the time of pregnancy and delivery. And there's been studies showing that SMM is rising in the US and in Canada. And we also know that SMM is closely associated with increased maternal death within 42 days of delivery. And also with is associated with increased readmission to the hospital within 1 year of delivery. But there weren't studies really examining SMM and risk of long-term mortality. And so I conducted a study to examine the relationship between SMM and the risk of long-term death. And this study was published in Obstetrics and Gynecology and won the paper prize award for the journal and the McGill-Lister Award. And for this study, I used the same Quebec hospitalization cohort, and the exposure was SMM, which was defined according to Canadian Perinatal Surveillance System. And then unexposed group with those who do not have SMM during pregnancy. So the primary outcome was hospital death any time after delivery, and the secondary outcome was death after 42 days of delivery, which was a novel piece since we didn't know what happened after 42 days. And we further classified long-term mortality into different time periods. So 43 days to less than 1 year, 1 year to less than 5 years, 5 years to less than 10 years, and 10 years thereafter. So women were followed from time of delivery to death of the study and period. And so we had up to 29 years of follow-up for some of these women. And then use cost regression models to estimate the hazard ratios at 5% interval, complex interval for the association between SMM and risk of mortality, and adjusted for some confounders like age and parity. In total, we had about 1.2 million women included in this cohort. Comparing characteristics of those that had SMN versus those that didn't have SMN, we saw that women had SMN more likely to be older, be nulliparous, have multiple births, so have like twins or triplets, and also more likely to have pre-existing comorbidity or socioeconomic deprivation. Now, looking at the association between SMN and mortality, we saw that if a woman had any type of SMN, then her rate of dying was 2 times higher compared with women with no SMN, because the reference group. And we also saw increased risk of mortality for all types of SMN, but most especially if the woman had cardiac complication, cerebrovascular accident, acute renal failure, or required assisted ventilation, then her risk of dying was 10 times or more greater than women who did not have any SMN. When we then looked at SMN and the risk of mortality after 42 days of delivery, we still saw increased risk. So women who had any SMN had 1.5 times the rate of mortality compared to women with no SMN. And similarly, there were increased risk for all types of SMN, and especially for cardiac complications, cerebrovascular accidents, and the other types of SMN that I mentioned previously. And we saw similar trends and results for across all the time periods that we followed. So the risk or the rate of dying was still increased throughout the study period, and especially for cardiac complications and ICU, even though the rate declined as time moved on. We also looked at SMN and the association with different types of different causes. So besides obstetric cause of death, which is death within 1 year, we saw that SMN was closely associated with increased rate of cardiovascular death, as well as death due to pulmonary related issues and neurologic death. So we concluded in this study that compared with no SMN, the SMN was associated with increased rate of dying after delivery, and was continuous throughout follow-up. And cardiac complications, acute renal failure, and cerebrovascular accidents were the leading morbidities associated with mortality after 42 days. And so our study suggests that there's need for closer clinical follow-up for these women, even beyond the initial postpartum period, which is usually about 6 to 7 degree. And the impact is that the study provides opportunity to identify women at increased risk early on for closer surveillance and prevention. So after doing this study where we saw that SMN was closely associated with increased risk of cardiovascular death, I decided to then look at the relationship between SMN and cardiovascular disease. And this study was published in Circulation Cardiovascular Policy and Outcome. Another reason for the study is that the burden of cardiovascular disease in women is much higher than men. So studies have shown that about 1 in 4 women would die in the first year of having a heart attack, compared with 1 in 5 men. And also there have been other studies showing that some other pregnancy complications, including gestational diabetes and stillbirth, are associated with increased risk of cardiovascular disease. Yet at the time when I was conducting the study, there was only one study looking at SMN as a whole and the risk of cardiovascular disease. And that study was from using Medicaid Pennsylvania claims data, and followed up only up to about 2 years later. And so for this study that I conducted, I used the Quebec data as well. And I defined SMN similarly using the PTS definition. And I excluded women with a history of cardiovascular disease that were interested in new or de novo cardiovascular disease. And I also excluded women who died of first. So the outcome was hospitalization for any cardiovascular disease after 32 days of delivery. We used 32 days because that's when SMN ends. And so cardiovascular disease examples were like heart failure, cerebrovascular disease, and admission coronary care. So for the analysis, women were followed from 42 days to the time of the outcome at the end of the study period. And we used time varying Cox regression analysis for this to estimate the hazard ratio and 95% confidence interval. and also adjusted model for confounders. So I had about 1.3 million women in this cohort, among which those with SMA had higher incidence of cardiovascular disease, as well as people who were older at time of delivery and also had comorbidity or substance use or socioeconomic complications. And when we looked at the association between SMM and cardiovascular disease, we saw that for those who had any type of SMM, their rate of cardiovascular disease was about 1.8 times higher compared to those without any SMM. And we saw increased rate of cardiovascular disease for all types of SMM, especially if the woman had cardiac complications, cardiovascular accident, ICU admission, or assisted ventilation. So we're finding similar types of SMA associated with long-term outcomes. And when we looked at the association between SMM and specific types of cardiovascular disease, we saw that SMM was associated with all types of cardiovascular disease that we looked at, but most especially heart failure, cardiomyopathy, and pulmonary vascular disease. So in summary for the study, we saw that SMM overall was associated with increased rate of cardiovascular disease after delivery, and the same types of SMM, cardiac complications, after renal failure were the leading morbidities associated with cardiovascular disease. And the study further reinformed that we still need to follow up with this women beyond the postpartum period. So after the study, I was thinking, and I was doing more reading, and I kept seeing studies talking about racial disparities in severe maternal morbidity, but I didn't see any synthesis or systematic review on what this racial disparity was. And so I conducted a systematic review to synthesize existing evidence on Black-white disparities in the prevalence of severe cardiovascular maternal morbidity. And this study was published in the American Heart Journal. So I set Medline, MBAs, and CNAL, and grouped the women to Black versus white racial and ethnic groups. And the outcome was severe cardiovascular maternal morbidity, which included acute myocardial infarction, peripartum cardiomyopathy, stroke, and then it synthesized the adjusted and unadjusted effects estimate. So for this review, we included 18 studies, all of which were published in the US. And it included about 7.6 million Black women and 26 million white women. And compared with white women, from the food ratio, we saw that Black women had increased risk, about 2 times increased risk of having severe cardiovascular morbidity. The study definitely highlighted some gaps because we did not see any studies published outside the US that were eligible for the study, even though we did not restrict our search. And also it made us think about what other factors could contribute to this, because we know that race is just a social construct, so not because of man is Black or a pregnant person is Black that they have this. And so we believe that the study is highlighting the need for public health intervention and more research in this area to address disparity in maternal morbidity. So now I've talked about like what I've mostly done for coming here. I just want to briefly talk about like what I've done to come here and like my future research goals. So I'm still working on under these domains, and I hope I'm going to work under this domain and explore more on what we can do to understand factors that are contributing to disparities in health between maternal health and long-term health. And I have a grant from CIHR, another grant on examining health of mothers after severe maternal morbidity in Canada. Some of the aims for this grant is to examine or estimate the risk of subsequent obstetric outcomes in Canada, such as recurrent SMM, and then also to examine the risk of subsequent non-obstetric outcomes. And overall, the goal is to assess the burden of SMM on women's health. So I just finished conducting and publishing a study on looking at the risk of recurrent SMM. This was published in AJOG recently, and then it got some media attention, and I was interviewed on the Canadian Broadcasting Corporation, and I just want to play that. So that
When we look at baby, we really need to see health center found that those who experience severe complications in their first delivery are 3 times more likely to face complications when giving birth a second time. That's that. When delivering a baby, even in 2023 in Canada. Researchers at the McGill University Health Center found that those who experience severe complications in their first delivery are 3 times more likely to face complications when giving birth a second time. The study has been published in the American Journal of Obstetrics and Gynecology. It looked at nearly 1 million pregnancies dating back 32 years in Quebec. Ugochi Vidianuka is the lead author and a postdoc fellow at McGill University in perinatal epidemiology. Welcome to our Montreal. Thank you for having me. What did you want to find out with this study? So we conducted the study because before now we didn't know what the risk of recurrent serious pregnancy complications were. There had been a few studies, mostly in the US, that had some pregnancy complications, smaller samples, and they had only examined exposure and outcome, but we wanted to look deeper into different types of pregnancy complications and see what those women's risks are for having a recurrence, and also to help guide clinicians on how to better manage this. So what qualifies as severe complications? So in this study, we intend to get maternal morbidity, and it's just a common thing for conditions that are unexpected and threatening the life of the mother. And this usually happens around the time of labor or delivery, or a few weeks before or after. And some examples are severe hemorrhage or bleeding, and also severe preeclampsia, which is usually characterized by high blood pressure and some organ dysfunction. We also have sepsis and cardiac complications. So those conditions that threaten the life of the mother, and also they have some serious long-term adverse health effects on the woman's well-being and health. So they are huge public health priorities. So the complications that you know that you're lead to long-term complications for the mother, I mean, are those also severe complications for the mother in the future, or are those kind of manageable lifelong complications? So we have some other studies that show that some of the women who have this serious pregnancy complications also have long-term risk of cardiovascular disease. But we didn't know much about what their short-term risks were, or the risk of recurrence in the next pregnancy. And so that was what we were more interested in the study. Okay. And how did you go about studying this? So we use a large provincial database. So we use the database from Quebec, and we analyzed over 800,000 women who had at least 2 deliveries in the hospital in Quebec. Now here in Canada, most women deliver in the hospital. We haven't been able to capture a lot of those women, and the cohort started from 1989, and we ran some regression analysis to examine the risk of this. Well, so you looked at more than 30 years worth of data. Are the risks the same for labor and delivery 30 years ago compared to giving birth today? So we did not necessarily examine that in a study, because we kind of adjusted or accounted for the time period of delivery in the regression analysis. So even if the risks are different over time, that would not have affected the estimate that we found. That's a good question. Somebody trying over time. Well, and that's something that a lot of women have experience with, especially if they have a big gap between pregnancies. That sometimes we find the follow-up is just so much more for the pregnancy now, in terms of technology, in terms of testing and vigilance, really on specific conditions, that you would assume there would be fewer complications and better outcomes. So it's probably definitely more. Canadian immune system that is different. And as you mentioned, even though you would expect that the complications would have reduced over time, that's not exactly what happening, even though they study that in the study book. But that's not what is being found. Instead, it appears that this pregnancy complications might be rising, and some of the reasons may be due to advanced maternal age. We know that women are given birth now at an older age than before. We assume that there's rising rate of comorbidity like obesity and also use of active services or food services. This is another thing that contributes to increasing rate of serious pregnancy complications.
You know, you looked also at second pregnancy as well as sort of the complications. So if you had in the study, if a woman had severe complications with the first pregnancy, what's the likelihood of them having it with the second or being more severe?
So if a woman has severe pregnancy complication in her first pregnancy, then about 6% of them had another complication in the pregnancy compared to 2% for women that didn't have any serious pregnancy complications in their first pregnancy. And comparing the two groups, so those who had serious complications versus those who did not in their first pregnancy, those men with serious pregnancy complications in their first pregnancy had 3 times higher risk of recurrence, compared to those that do not have any serious pregnancy complications. And we also found in a study that the types of complications, the consequences depended on the type of complications. For example, if a woman had severe eclampsia in the first pregnancy, then her risk was 4 times higher. Whereas if she had cardiac or heart-related complications, then she even had 7-fold higher risk of having recurrence in subsequent pregnancy compared to those who did not have that complication.
So now that we have this information, what will doctors and patients be able to do with it?
That's a good question. I believe many women who have this complication would like to have children but are afraid or don't know what their risks are for the next pregnancy. And so the estimates that we provided can help doctors counsel women about their pregnancy. Also, a lot of the pregnancy complications can be prevented by early identification of high-risk patients and treatment. For example, a doctor can plan to induce delivery for high-risk patients rather than wait and then it leads to unplanned or emergency cesarean section. Also, if you identify high-risk patients early enough, then you can transfer to higher specialty of antenatal care. There's also potential possibility for treatment for those women. There's been studies that show that low-dose aspirin can help in the prevention of severe preeclampsia. So if we can identify women with high risk of severe preeclampsia, then we can treat that earlier. And so we're hoping that all this information from the study will help to guide the management and better prepare the healthcare system so to prevent the recurrence of the complications that can kill the mother.
Well, you know, women know that there are problems with the medical system in dealing with any illness, whether you are pregnant or not. Along with the reproductive system, I think medical practitioners need to change the way they follow up with patients, even after they give birth. I mean, I have anecdotally, you know, people who told me that they had severe complications during pregnancy, and then after there was no follow-up. Nobody even spoke to them about something that could happen in the future. I mean, that is something that needs to be rectified. There should be follow-up.
Yeah, absolutely. And you just nailed the point because the key is following up with women after birth. Even before discharge, to make sure that the women's blood pressures are well controlled and they're in good shape and form to discharge. And to track to them, if you can identify those patterns, to stress to them that they need to come back to the clinic. And also there has to be some sort of statement in the system where we can easily keep following up with this women by calling them and checking up with them. I know that in some other places they have some home postnatal care where nurses go and visit the women. Okay, but I think things like that, where you have midwives and other kinds of healthcare providers might help to improve the health of women.
Well, let's see what happens coming out of this study. Ugochi, thank you so much for joining us. I really appreciate it.
Thank you for having me.
Ugo Shigunian Uka is the lead author of this study and a former postdoc fellow at McGill University in perinatal epidemiology. Published in the American Journal of Obstetrics.
Yeah, that was a new shot into it, and then we went. I think that. So, conclude the take home point, I said earlier, pregnancy complications, especially hypertension pregnancy and severe maternal associated with short and long-term outcomes in women, and there's some significant disparities, expectation disparities, in different pregnancy complications. So, the use of prediction models can help us especially identify the women and highest risk of further morbidity and definitely need more work in this area. So I like to acknowledge all my previous and co-authors the manager, and then I'll get to this quote, which is from the national novel, and the quote goes like this: if you don't understand, ask questions. If you're uncomfortable about asking, say you are uncomfortable about asking questions and then ask anyway, then listen. Sometimes people just want to feel here's the possibilities of friendship and connection and understanding. Thank you all.
Thank you so much, Lucia. Thank you for the invitation for questions. Anyone have any questions?
Georgie, we're so happy you're here. Both your role and her role. So the question is, in the interview, you spoke about the importance of the G1, the obstetrician, either high risk or the subsequent pregnancy. But it seems to me also that there's a very important role for the general practitioner in the pregnancy period. And so I'm wondering, in your analysis to that paper, if you were able to account for any treatments or interventions that she may have had during her pregnancy period, owing to the fact that potentially any successful intervention during the pregnancy period may have reduced the risk of subsequent.
Yeah, so that's really a good question, because we thought about it and how we could account for whatever treatment in between. Unfortunately, we didn't have that data because it was hospitalization data that we had. And so we even think that the risk or the risk estimates that we're seeing might be more biased or lower, because if some of these women had Africa in the pregnancy phase, then maybe that may have this comparison patients. So as you pointed out, we need the GP as well as the obstetrician, because once the woman delivers after 2 days or 6 weeks, supposed to be handed over to a GP or internal medicine specialist, depending on her condition. And so those people need to know what's going on and start treatment and follow up with them, because there are many women who are just lost once they deliver. They can't come back for several reasons. And some of which, even though my study was in Canada, but here in the US, that sometimes people with insurance after a while, even though I think the US is trying to do something about it for that. So it's important for us to communicate with subsequent care providers. So I haven't looked at that yet, and hopefully I can find some good data so I can see if that maybe the website that SMM.
A great presentation. I think I actually had a follow-up question to that. So I've been interested in looking at the association between hypertensive disorders of pregnancy and like future or subsequent development of subsequent chronic hypertension. And I'm interested in seeing if that association is modified by initiation and timing of postpartum primary care. But in terms of context, I know that the Quebec database is a lot more robust than what we have here right now. So if you were to look at something like that in the US context, like what would you consider like hospital-based like records or like claims data? And I know you mentioned some people would lose their insurance during that period. So what are some thoughts that you have around that if you were to do that here?
Thinking around the area, and I was thinking more about, not just using, hospital media, that sometimes it doesn't have some very good damage, one has to be a hospital, but you can have access to some health records and see how often the blood pressure, monitor, kind of labs, and some form of healthcare utilization. So maybe how many times that they think a care provider and the types of medication from pharmacy, that might give more information about the type of care that she's receiving. Now, I don't know what to do as far as like if the woman doesn't have any access at all. So okay, if she doesn't have health care insurance, so maybe that can be accounted. Or if you use only those that have insurance, that doesn't generalize it. So maybe we should talk with the government. We looked at estimate as a whole, so like estimate including all the different types that are listed by the. And then if the woman had any SMM, well then there were some that we also tried to look at the type of SMM and the requirements from the results for most of them, even though we couldn't do that for all of them because some of them have more but then for most of them that we looked at the type of SMM was similar, although a woman can have more than one type.
I'd be curious to hear a little bit more about what you're doing now since you've been at Health Partners and how you are kind of leveraging the network that Health Partners is part of and the Minnesota EHR consortium.
So something I'm working on right now is like I'm looking at medication adherence. Since we have electronic health records and we have the claims that I'm doing, so I'm looking at medication adherence and antihypertensive medication. And so that kind of gets into whether this woman, even when they're prescribed medication during pregnancy, like are they taking it? And maybe that could also help us understand why some of this pregnancy complications are recurring. So that's something that I'm looking at right now. And then I'm also doing some other like pharmacotherapy stuff as well, but I do like talk about pharmacotherapy.
Thank you for the presentation. I was wondering for the women who have preterm epidemic, like what are some of the characteristics that they show? Like maybe the socioeconomic.
Right. So it's kind of similar to what I saw in other studies. Like, so if a woman was older at the time of complicated pregnancy, so it's like a 5 years old, or she had some pre-existing like obesity or like something like smoking, alcohol, like during her pregnancy. So the same things were occurring in all of the studies that was at the high. Obviously, there's some people who don't have any children still have.
I was just wondering, have you looked at in any of your studies, have you looked at the variables related to menopause, in relation to, CVD outcomes? Probably something related to hormonal changes or removal of ovaries or, uterus, anything related to that and its relation with CVD?
No, I haven't looked at that yet. So and I don't know much about menopause, but I think that there's some literature about that and increased risk, I think. But sometimes it might just be related to aging, but I haven't
evidence here, like, you know, for instance, if someone says severe morbidity, these are folks who are already at risk for a lot of severe outcomes throughout life.
Yeah, there have been different theories, different hypotheses proposed as to why we see the pregnancy complications and long-term outcomes. And one of that is that some of these women already have underlying conditions or even cardiovascular conditions that have not been diagnosed, because if they don't come to the hospital, whatever, they're pregnant, that may be the best doctor examines that. So sometimes some of those men are already at high risk. And so the stress of pregnancy, because some people consider pregnancy as the stress that is like because of all the physiological changes. So the stress of pregnancy can then worsen that condition for them. And then sometimes it might just be that the things that happen in pregnancy, like you said, called placentation, like that doesn't develop well, then for whatever reason, then the man then becomes prone to some of this pregnancy complication as a outcome. And I don't know much about like if they treat the woman, whether we believe that if they treat the woman to help prevent like subsequent pregnancy outcomes and long-term outcomes, but it could also just be that it might be delaying the occurrence of it, because even with the low dose aspirin, yes, we see less cases of preeclampsia, but sometimes it's still like late onset preeclampsia that happens like after 2 weeks gestation. So it's not really clear yet.
So in terms of looking at health disparities, I know you presented differences between like Black and white women. I am interested in how like nativity influences this relationship, and especially for cardiovascular disease. There's a lot of literature out there, in terms of like immigrant health, how for immigrant women, they don't experience the same risks as their native born counterparts until I think like after 10 years or so. But in terms of looking at like future cardiovascular disease, have you ever looked into like nativity to see how sort of those experiences are not homogenous across like Black women, for example?
No, I haven't looked at that yet. And I think that there is the different outcomes and how it looks like immigrants are healthier, the healthy immigrants, if that like they're healthy at the beginning, and then maybe at time they start settling into and the new country and following the same lifestyle, eating, and then their risk starts to follow the people who are there. But I don't know in terms of long-term cardiovascular disease. That we have
One more, maybe I can have a question about it. Only one more question. So I really liked your opening slide where you showed all of the different institutions you've been at, and really how you done research in the institutions all over the world. You're new to the United States, you're new to Health Partners. And I was wondering just if you could talk a little bit about, since you've been at so many different types of places, like what drew you to come here to Minnesota and to Health Partners?
a lot of things, but I would say that I came here because I thought that there'll be a better opportunity to look more at racial disparities and outcomes. In Canada, I have access to like Black database, but the thing about the health database in Canada, as a part of it, we don't really collect information race ethnicity, and there's a different topic, but like the reason was that they didn't want any discrimination, well, in that, but now research is advising to do it. So, I want to be in a place where I could examine more of that, and also because we see all the, on the news, and communicate like all the things that happen, here in the US regarding racial discrimination, racism and health outcomes, and all the like lack of, parental leave and all the, so many issues with maternal health care. So I wanted to be in a space where I could, work with people, work with data, to examine more of that. And as one of my friends said, like, why don't come to US and have another country and it's like.
So you came to the US because it's such a terrible / interesting place. I just want to say thank you so much. Thank you for coming over to visit us. You're always welcome here to W Bob. I'll see everyone next week. If you're a doctoral student, you are invited to stick around for another maybe half hour to chat with Yoshi. Everyone else, you're around. Thank you.